Okay, we are live on YouTube. Okay, we are live on YouTube. Right, so Dr. Fatah, are you ready to start? And I'll press record. So actually, just before you start, I will, if you wouldn't mind, could you just move on to the next few slides?
Yeah.
Could you please move on to the next slide as well?
Your next slide.
Yes, please. Right, so as all of you know, that we have a really, really generous series giveaway. The rules are really, really simple. So the more lectures you attend, the more times your name will be added to our draw, providing you've completed the feedback and you have a certificate. So I can't encourage you more to fill out the feedback form, please, for our lecturers and also for us. And you stand a great shot at winning some of these fantastic prizes. So as you can see, you could win a Oxford Handbook, you could win QuesMed Question Bank single best answers, you could win a skull, you could also win a suturing kit and electronic digital podcases app from Scrubbed In. We're incredibly privileged to have partnered with all of the organizations that you can see at the bottom. And I would just like to give a big thanks to Scrubbed In, OS Implants, My Suture, QuesMed, and also Anastomosis and Medal, which provide us with great linking opportunities and you know, for all of the feedback and certificate systems which are in place to help you guys get some nice certificates for your own portfolios. So with that, you know, at the end, if you all stay till the end, I will be posting the feedback link, and it will also be accessible via QR code as well. So please stay till the end. And yeah, hopefully you'll be learning a lot in the next slides from Dr. Vataha. And so yeah, with that, Dr. Vataha, please could you start your lecture?
Yeah. So thank you, Stephen. Thank you for this opportunity to discuss the topic of cardiovascular examination today. So I work at the Liverpool University Hospitals, NHS Foundation Trust, and work at Maastricht University. Now the lecture is quite long, so I'll start straight away. And in terms of what I would like to talk to you about, first I'll just go briefly talk about some philosophical stuff very shortly. Then we're going to have a look at the neck veins and examination of neck veins, palpation of the heart, auscultation of the heart, peripheral signs of heart disease. We'll touch on the topic of volume status, and we'll finish with the sequence of the examination of cardiovascular examination. As I said, this lecture is the topic is very broad, so please, and apologies as if I've missed anything that you were expecting. So this is a famous painting called The Physician by Luke Fildes from 1891. It shows a physician sitting next to a sick patient, thinking, being puzzled by what's going on, thinking about pathophysiology and, you know, the correct diagnosis and what the best treatment plan is. Until last century, medicine and diagnostics have been mainly focused around clinical and bedside assessment, starting with careful history taking and thorough physical examination. Further investigations were not done routinely, and it's because they were not available. Medicine relied mainly on the hands and the eyes of the doctor. But nowadays, it is quite the opposite. We rely heavily on the technology and investigations, and the bedside manners and skills slowly drift away. So is there a role still for a bedside clinical examination, and should it matter that much? Physical examination is tested as any other. It has its precision, accuracy, sensitivity, specificity, and there is a degree of variability in interpretation. While clinical examination can be definitely useful, and in some cases it is irreplaceable, you should know and you should be aware of its limitations. While doctors in the past were great at auscultating murmurs and examination of neck veins, it was also because patients often were undertreated simply due to lack of treatment and developed profound clinical signs that could have been easily picked up. Nowadays, you don't see asymmetrical chest expansion in lobar pneumonia anymore, and it's just simply because no one develops lobar pneumonia. It is diagnosed, the pneumonia is diagnosed and treated much early. So, but equally, on the other hand, in 21st century, with availability of echocardiography, you cannot rely on only auscultatory findings and diagnosis of valvular lesions. You will not refer someone for valve replacement only after just auscultation. Equally, you will not diagnose interstitial lung disease from just fine crackles. What I'm trying to say is, I highly encourage you to spend time at bedside with the patient and learn as much as you can, but also be aware of all the limitations that the bedside examination has. So I've tried to make these lectures as useful as possible as can be, but there are limitations to online lecturing, and clinical examination can only be mastered at bedside. So take it only as a primer to get your attention and stimulate your interest, and to provide just basics for the practice. So moving on to the first topic, the neck veins. So neck veins, a little bit of history. Neck veins were first associated with heart disease in 18th century by Morgani. Though venous waveforms were extensively described by Sir James Mackenzie in the early 20th century, venous pressure, on the other hand, was largely ignored. Nevertheless, labels he used to describe components of venous pressure waveforms are still used today. First, he used simple sphygmograph to detect venous pulse, then that he later upgraded to polygraph to simultaneously measure arterial and venous pulse. It allowed him to study waveform abnormalities in cardiac arrhythmias and heart disease before the era of ECG. In 1902, after years of studies, he published this unprecedented book about his findings. Venous pressure measurement was possible only after discovery of direct antecubital veins cannulation and use of glass manometer. Ernest Starling in 1912 to 1914 first investigated the link between venous pressure and cardiac output. In 1920s, bedside venous pressure estimate became a routine clinical practice guiding treatment of heart failure. In 1930s, Thomas Lewis, British cardiologist and student of Mackenzie, introduced a simple bedside examination method that is still used today. It's sometimes referred to as method of Lewis. So, and the examination of the neck veins was hugely popular until 1970s, when it started to drop, and as you guess rightly, it's with the invention of the echo. So there are two aspects to examination of the neck veins. The first is the pressure itself. Jugular venous pressure is an indirect measure of central venous pressure, therefore can help with the diagnosis of heart disease. And second is venous pressure waveform. This is a complex thing to interpret at bedside, difficult to memorize, and overall has fallen out of favor over the years simply because of modern, much better methods of investigations of heart disease, arrhythmias, and valvular defects. Abnormalities of these are beyond the scope of this lecture, and unfortunately, I'm not going to touch it, or fortunately for me, I'm not going to discuss it. When it comes to jugular venous pressure, it is as I said, indirect measure of central venous pressure, which represents mean pressure in vena cava, or the right atrium. It can be expressed in millimeters of mercury or more, commonly at bedside in centimeters of water. Bedside examination can accurately estimate central venous pressure. However, there is a bit of a error in measurement, and plus or minus 4 centimeters, it is accurate of true CVP. However, measurements of CVP are only as accurate as external reference point chosen for the physiologic 0 point, or like point where there is zero venous pressure in the right atrium. And the external reference point we use is the sternal angle. It is reliable and accurate external reference point that Thomas Lewis used for his bedside examination. The physiological point 0 lies 5 centimeters below the sternal angle when the patient is supine, semi-upright, or upright. So as you can, however, there is an inherited error in this, as you can see in the image. So in all cases, the true CVP is 14 centimeters. When we measured in supine position, is plus 5 centimeters plus 5 centimeters to the reference point. In semi-upright, it's plus 2 centimeters, and in upright, it's again 5 centimeters. So it ranges from 7 to 10 centimeters, just purely based on position of the patient. As I said, it is relatively accurate, but plus or minus 4 centimeters. Studies have found out that the bedside measurements of CVP are accurate within 4 centimeters of water 85% of time when compared to invasive techniques. So you can use, you probably have been told, but you can use only internal jugular vein to examine jugular venous pressure, but it doesn't matter. You can use external or internal, and you can use right side or left side of the neck. It doesn't matter. But the right side is much nicer to visualize. And the upper limit of normal of JVP or CVP is 8 centimeters. So if you see it above 30 centimeters above the sternal angle, then you can presume the CVP is elevated. And so in the context of how to do it, you should obviously have patient lying on the bed, supine, relaxed, and elevate the head of the bed to 30 degrees or 45 degrees, adjust as needed later. Expose the right side of the neck, make sure that the head is back and nice and relaxed and supported by the pillow or the bed, and so that there is no tension in the neck. Then you should identify the pulsation just by to differentiate the pulsation of the venous and arterial system, and I'm going to touch about that just in a minute. And then you focus on venous waveform. Plus or minus, you auscultate the heart to know exactly what you're looking at. So how to differentiate whether this is arterial or venous pulsation? There are many characteristics. In arterial pulsation, classically, the movement is ascending. It goes up and it goes outward. In the venous, it descends and it goes inward. Arterial is palpable, and it is not occludable. Venous is occludable, just with light touch. And arterial has got only one pulsation per cardiac cycle. The venous, typically in a healthy person, has 2 pulsations, even in disease, but there can be variations. Arterial pulsations do not change with respiration, but the venous pulsations decrease on inspiration, increase on expiration. Venous also changes, venous pulsations increase on abdominal pressure, but only temporarily. This is called abdominal jugular reflex, until it usually the heart usually adjusts itself within 30 seconds. And venous pulsations increase when you lower the patient, when you lower the head of the bed, but the arterial pulsations do not change. So now about the waveform. This is, as I said, this is very difficult topic, and I've learned it so many times and I forgot it so many times that I'm just relearning every single time. Here you can see a venous pulse on the sphygmomanogram with all the waves and descents, A wave, X descent, C wave, X descent, V wave, Y descent. This is what you see on the tracing, but you won't see all of this. At the bedside, you only see this. And you see two pulsations. You see A wave and V wave, and two descents, X descent and Y descent. I'm going to go through this because it's very difficult. I'm going to try to show you how to memorize this. So A wave represents the right atrial contraction, and it coincides with the S1. X descent is right atrial relaxation. C wave is representative of right ventricular contraction. X descent, I don't even know what's the English word for it, is right ventricular relaxation again, and right ventricular system and right atrial relaxation. V wave is venous filling of the right atrium, and Y descent is emptying of the right atrium into the ventricle. It is very complex thing to remember, and you won't need that in the modern clinical practice, in all fairness. But as a demonstration, this is a very nice video, and I highly encourage you to watch all the lectures and all the videos of from Stanford 25. They have excellent videos on bedside medicine.
In the examination of the neck veins, we're trying to determine two things. One, what is the jugular venous pressure? And secondly, what are the waveforms like, and are they abnormal in any way? The first task is to find the pulsation of the neck veins. And so we're seeing a pulsation here and another pulsation here. And the question is that venous? To call something venous, we have to apply a few criteria. If it's a venous wave, it'll have a bifid flicking quality. It will definitely change with the respiration. So as he breathes in, you see it sink down. As he breathes out, you see it sort of rise up in the neck again. It'll also change with the position of the bed. So if we were to sit him up, it would sink down. If we lay him back, it would be much more visible. So applying all those criteria, and also the fact that it's not palpable, venous pulses are not palpable, whereas arterial pulses are, we conclude that this is a venous wave. And I'm now going to turn the lights down just so that you can see this a little bit better.
I'm sorry.
And we're going to focus on the two waves. The first wave is called the A wave, and the second is called the V wave. A wave represents atrial contraction. It happens just before S1. The V wave happens from the AV valves bulging back into the atrium, and it happens just after S1. But if his heart rate is slow, which it is, he's going at about 65 or 66 a minute, you could actually call the neck veins out just by observing them coming in couplets like this. So I'm going to call them out for you. AV, 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 AV. And these veins are, these waves are not abnormal. There are many abnormalities of the A and V waves and the descents that are to be found in the text. We're now going to measure the jugular venous pressure. And so what we have to do is to measure it and see how far the highest level of this venous impulse is from the sternal angle. Here's the sternal angle. I'm going to draw a horizontal line from the highest point of the venous impulse. And then my task is to measure the distance between this horizontal line and the sternal angle. Let's say that the distance between my ruler, let's say the distance was about 2 centimeters, that the upper border of that venous impulse was 2 centimeters above the sternal angle, we would now add 5 centimeters to get to the center of the atrium, and we would report that as a jugular venous pressure of 7 centimeters.
That was Dr. Verghese, and I'm always amazed by his bedside skills. But if you're really interested in this topic, there is an excellent, absolutely excellent, a true gem, a film on jugular venous pulse. It is about half an hour long on YouTube. If you just find it by this title, it is an excellent. It's got all the pathologies. Just I highly encourage you to watch it. Obviously, I'm not going to play it here. I'm gonna let you ask any questions at this point because there is a lot to talk about. So if you have any questions, feel free to fire now before we move next to the palpation of the heart. Yes, so the question is whether it was 5 centimeters plus the height. So the sternal angle is as a external reference point, and at that level, this point 0 is 5 centimeters below. So anything above the sternal angle, you must add 5 centimeters to it. So if it's 3 centimeters above the angle, it's 3 plus 5, and the total pressure is 8. So it's 5 plus whatever you see above the sternal angle. Right, so we're going to move on to the next. Palpation of the heart. First, I'm going to touch about the chest topography. Quickly revise that, there is the sternal angle, and there are these vertical lines, the lateral sternal line, the midclavicular line, and the parasternal line. These are the reference points that I'll be talking about later on. When describing precordial movements by palpation, you should tell it location, size, timing, and type of the movement. The location and the type of movement are probably the most important and have the most diagnostic value. Then there is the topic of the terminology. And as with anything in medicine, terminology is key, and unfortunately often archaic and traditional descriptors are used. The best way to describe the movement is simply by calling it cardiac impulse or precordial movement. Thrill is used for palpable murmurs, but they're rare nowadays, and you don't see that very often with echo and valve replacement. But more often you will be able to feel individual heart sounds, and you just talk about palpable heart sounds. Equally, you can just talk about palpable murmurs. Heave, lift, or thrust should be avoided, as these are used inconsistently, incorrectly, and do not add more value to the terminology proposed before. So, location, where should you feel for precordial movements? The first region is, or one of the 4 regions, is the apex. Despite its name, it doesn't have any consistent relationships with the anatomic apex of the left ventricle. And perhaps the best way to call it is just the point of maximal impulse. Then there is parasternal, lower parasternal area, right base or right upper sternal border, and left base or left upper sternal border. Right base is sometimes referred as aortic, and left base pulmonic. There are 4 types of systolic movement that you can feel. There is normal systolic movement. It is a small outward movement that starts with first heart sound and ends mid-systole. It is more palpable in left lateral decubitus position. Then there is hyperkinetic, which is similar or almost the same as normal, but only its amplitude is exaggerated. And to tell the difference between those two is very subjective, because in patients, in thin patients, the impulse can be felt more easily and is not necessarily hyperkinetic. So it's quite difficult and subjective. Sustained movement is abnormal outward movement that begins at S1, but unlike those previous movements, this one extends into the second heart sound and even beyond that before it descends to its original position. It is always abnormal and indicates either pressure overload of left ventricle, volume overload of left ventricle, or a combination. It can also be felt in severe cardiomyopathy and ventricular aneurysm. And the last type of movement is retracting movement. It's an inward motion that starts at S1 and outward movement starts in early diastole. They are a bit more complicated and difficult to distinguish, and I think we're just going to leave it at that. As myself, I don't even have much experience with retracting movements. Apical movements or apical impulse or apex beat or point of maximal impulse can be felt in apical area as shown before. Usually, apex beat is felt at 5th intercostal space in mid-clavicular line. When displaced laterally, it means that there is a heart, or there can be a heart enlargement. And here are some useful signs. So if you have a lateral displacement, there is a very good likelihood ratio of 10.3 that the patient has low ejection fraction, therefore it's got a systolic heart failure. There is again, very good positive likelihood ratio that patient has increased left ventricle and diastolic volume, or like volume overload. And there is an increased likelihood ratio that there is an increased pulmonary capillary wedge pressure. So increased backward pressure on the lungs, potentially causing pulmonary edema. That is quite a lot of useful information, even without bedside echocardiography. Here is a video of how to assess the precordial movement, or sorry, apex beat. Skip it.
For the apex beat. This is the most inferolateral point where the pulsation of the heart is palpable. When it is found, identify its anatomical location to determine if it is displaced. It should be located in the 5th left intercostal space on the midclavicular line. If it is impalpable, locate the 5th left intercostal space on the midclavicular line as the first location for auscultation.
There you go. Next to lower parasternal movements. Lower parasternal cardiac movements are usually not felt. When they are felt and sustained, it can be due to various reasons. Similarly, as with apex beat, it can be due to pressure overload of the right ventricle, as in pulmonary hypertension. And it can be due to volume overload of the right ventricle, as in atrial septal defect. Or it can be due to left atrial enlargement, as in a severe mitral regurgitation. And here is a quick video on how to examine parasternal movements and actually even the base of the heart.
Feel for thrills, which are palpable murmurs. Next, feel for parasternal heave, which is evident in right ventricular hypertrophy.
So, any questions before we move on to the most difficult part of this lecture, and that's auscultation of the heart? It's not that difficult, is it? Palpation of the heart. Okay, I'm gonna move on to the auscultation. Oh, arterials and so the question is: arterials and heaves difficult to observe in obese patients? Yes, is the short answer. Definitely. So it's much easier to appreciate in someone who's thin, and with obese patients or with someone who's got increased adiposity. It is difficult, and also the findings can mislead because in obese patients you tend to have lateral displacement of the apical beat anyway, and doesn't mean that the patient has heart failure. It's just because there is an increased abdominal pressure that the heart sits more flat, or say the axis is deviated to the left, and yeah, so it can mislead. So moving on to the auscultation of the heart, and you're gonna get another short history lecture on stethoscope. Auscultation was known to physicians even in the times of ancient Egypt, and Hippocrates tried to listen to the body sounds by applying the ear directly to the chest, trying to detect any accumulation of fluid within it. This immediate auscultation was the only method of auscultation until the discovery of stethoscope in 1816 by René Laennec. Laennec was a French physician, a skilled woodturner, and also a flutist. You can see him examining a patient's chest with immediate or so-called direct method, placing his ear on the chest of the patient. When in 1916 he was examining a young female patient, he felt embarrassed to place his ear to her chest. So instead, he rolled up 24 sheets of paper and placed one end onto her chest and the other one, into his ear. To his surprise, the sound was was conveyed louder and clearer than with immediate auscultation. His particular sets of skills as a woodturner were useful in developing new instrument of auscultation that he called la cylindre, pardon my French. It was a two-part, 12 inches long and 1.5 inches thick wooden cylinder for listening of the lungs, with another removable cone-shaped plug used for listening of the heart. Finally, unsatisfied with the names given by his colleagues, he decided to call it the stethoscope. You can see the first stethoscope of Laennec when examining the boy's chest in the picture. And in 1819, he published his famous work, A Treatise on the Disease of the Chest. The peak of auscultation of the heart was in 1950s to 1970s, with a decline in late 1970s. As mentioned earlier, it was because of two reasons. One, it was the invention of the echocardiography, and second, it was in the States. And second was the fact that the insurance company in the States, they stopped reimbursing the phonocardiography. And it is worth mentioning that the first echocardiography was used in 1953 by Swedish physician Inge Adler. So when it comes to general principles of the auscultation, as with anything, you should know the equipment you're using, and also know that the equipment is only as good as the person who's using it. Modern stethoscopes have excellent performance. Traditionally, it is thought that the bell of the stethoscope conducts only low frequency sounds, and that's not true. It conducts all frequencies well, but if mixture of frequencies high and low is present, low frequency sounds can mask high frequency ones. The diaphragm filters out low frequencies and transmits high frequencies only. if you want to gather any useful information in any exam, especially in auscultation of the heart, you need to work in the silent room. Patient needs to be exposed so that there is a direct contact of the stethoscope to the skin. Hair on the chest causes air leak and can diminish the auscultation. However, and this is important, the most common air leak is, or when the air leak is present most commonly, it is due to poorly fitting earpieces. So make sure that you got this tight, because only minimal air leak can significantly impact the transmission of the sound. And I was reading some numbers, and it's quite significant. And you can even tell that yourself when you're auscultating. So you should listen to the heart sounds in 3 positions. Generally start in supine position with the elevation of the head of the bed to 30 degrees, just for general auscultation. Then move on to left lateral decubitus position. That's best for the 3rd and 4th heart sounds and the murmur of mitral stenosis. And then in upright position, that's best for auscultation of the splitting of the 2nd heart sound and aortic regurgitation. When it comes to heart sounds itself, you should, again, try to describe its location, timing, intensity, duration, pitch, and quality of the sound. It's a lot of information to gather just from listening to the heart sounds, but the main important piece of information is the location where you hear the heart sound, the timing, or maybe the timing is the most important. Whether it's a systolic or diastolic, and then the intensity, whether it's loud or soft sound. So again, the location for auscultation. Traditionally, locations for auscultation of the heart sounds are described as aortic, pulmonary, mitral, tricuspid area. However, this is misleading, as some murmurs are audible throughout the precordium. I think the best approach is to describe the location just anatomically. In the 2nd intercostal space at the right upper sternal border is where typically aortic valve murmurs are heard. Opposite to that is left upper sternal border is where pulmonary valve murmurs are classically heard. Left lower, the apex or the point of maximal impulse or the 5th intercostal space in mid-clavicular line is place for mitral valve murmurs. And then you've got the left lower sternal border for auscultation of tricuspid valve, ventricular septal defect, and murmur of aortic regurgitation. So I think the best way is just to describe it anatomically. Then there are other regions that you should listen to, and they are for radiation of the murmurs. One is axilla, for the radiation of mitral regurgitation, and carotids for in case of aortic stenosis. There are other places such as left infraclavicular infraclavicular area, or back, as in, for example, in patent ductus arteriosus. Timing. To understand what you are hearing, you need to identify systole and diastole, and identify individual heart sounds and heart murmurs. There are 3 ways to identify systole and diastole. One is by the cadence of the sound. When the patient is rate controlled, that means when the heart rate is nice and slow, systole is shorter and the diastole is longer. It is easy to distinguish 3rd and 2nd heart sounds, and it sounds like this: lub-dub, 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 lub-dub. And you can tell there is a pause between, and obviously. However, when patient is tachycardic, diastole shortens, and all sounds are close together, and it is difficult to distinguish one, from the other. The 2nd way is by characteristics of the heart sounds. 2nd heart sound is much snappier, the dub, and the first, and it is louder, especially in the left, along the left sternal border. The 3rd way, that for some reason is allegedly the only way in the UK exams, is by palpating carotid impulse. Carotid impulse is felt shortly after the first heart sound in rate-controlled patient. But again, if the patient is tachycardic, it is nearly impossible to tell by this method. By the way, this lub-dub thing of myself is the way of describing heart sounds in words, and it is called onomatopoeia. Onomatopoeia, and it is I think the best way how to learn auscultatory findings, and we'll get to that in a second. So first heart sound. The exact mechanisms how the first heart sound is generated is not known. What is important, however, it is that it coincides with closure of the mitral and tricuspid valves. Intensity of the S1 is the most important characteristic, and it primarily correlates with the strength of ventricular contraction. First heart sound can be loud, faint, or absent, or can have varying intensity. When it is loud, it can be due to vigorous ventricular contraction, such as in sympathetic stimulation, or delayed closure of the mitral valve, for example, in mitral stenosis, prolapsed mitral valve, and left atrial myxoma. In contrary, faint or absent S1 is heard in weak ventricular contraction or in early closure of mitral valve. When there is beat-to-beat variation of intensity of S1, that means that ventricular filling is different beat to beat. Now, this is a bit difficult to understand, or a bit difficult for me to explain. So when the heartbeat is irregular, it has no significance, as simply that's, the filling of the ventricle depends on the time that it has to fill, and it's irregular with the irregular heartbeat. However, when the heartbeat is regular, or when the pulse is regular, it means that there is atrioventricular dissociation with variable PR interval, and that the atria are contracting independently of the ventricles, and there is different filling, beat to beat. So in that setting, you can diagnose a AV dissociation, or like third degree heart block. First heart sound can also be split due to right bundle branch block or ectopics in left ventricle, but this is not very common and sometimes tricky to differentiate. Second heart sound represents closure of semilunar valves, the aortic valve, also known as A2, and pulmonary valve, or P2. The intensity is the most important characteristic in the first heart sound. Splitting is the most important in the second heart sound. And the splitting is physiologic when recorded. You always see splitting when it's recorded by the phonocardiogram, and that's physiological, and that's normal, and it's always present. However, we as a human, we can't perceive it as a split heart sound, and we hear it as only as a single sound. Some people are unable to hear the two sounds even with the inspiratory maneuver. Splitting is best heard along the left sternal border and in inspiration. And we're going to touch about the maneuvers later on. This physiological splitting occurs because of low pulmonary vascular resistance, and that the flow across the valve continues even after the right ventricle has been emptied. It is not that the right ventricular systole ends earlier than that of left ventricle, as is traditionally thought. So basically, the reason is the pulmonary vascular resistance is much, much lower, and there is still a flow. Inspiration can also causes increased filling of the right ventricle and lengthens the right ventricular systole, and reduces filling of the left heart and shortens the left ventricular systole. So here you can see the physiological splitting. You can see the first heart sound and the second heart sound that physiologically split, but you can't appreciate it just by listening. So what you can do is to ask the patient to breathe in, and as they breathe in, the heart splits. This is physiological. Then you can have pathological white fixed splitting of the second heart sound, and that's when there is no change with inspiration, and that is seen, for example, in patients with an atrial septal defect, as it is a left to right shunt. There is an increased flow across the right heart, and there is a prolongation of the right ventricle systole. Then there is something called paradoxic splitting, where you normally on expiration you hear split heart sound, but you hear the pulmonary component first and aortic after, and therefore when you breathe in, the pulmonary component occurs later or is delayed, but it comes closer, and therefore the splitting paradoxically disappears. This can be seen in, for example, in conditions that causes delay of left ventricle systole, like in left bundle branch block, or prolongation of the left ventricle emptying, like aortic stenosis. It is also worth mentioning that traditionally, and this is also the case of the PACEs in the UK, that loud P2 is regarded as a sign of pulmonary hypertension. It's not true, and studies has confirmed that it's not a reliable sign, and actually it's normal. So please don't say if someone's got a loud P2 that they have pulmonary hypertension, unless you're in PACEs. The third heart sound is caused by rapid diastolic filling of the ventricle and appears in early diastole immediately after second heart sound. It can be physiological if present in a patient of less than 40 years of age, but when the patient is older, it indicates older than 40 years and they have S3. It indicates severe systolic dysfunction, valvular regurgitation, or left to right cardiac shunt. And it's, it sounds like this: loop de boop, loop de boop, loop de boop, loop de boop, loop de boop. There's also this mnemonic or another technique, and it is heard as a Kentucky, 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 Kentucky. The gallop is a triple rhythm and is always pathological, and therefore it excludes physiological S3. The third heart sound is most commonly heard in patients with congestive heart failure. Remember that it is not always present in all patients with congestive heart failure, but when you hear it, it has great likelihood, positive likelihood ratio for congestive heart failure. So when you hear an S3, you can be almost sure that the patient has congestive heart failure. Fourth heart sound is also caused by rapid diastolic filling but this time it's abnormally stiff ventricle, like in hypertrophy or fibrosis. It appears in late diastole just before S1, and it is always pathological. And S4 gallop sounds like this. Where is it? Always pathological sounds like balup dup, balup dup, balup dup, balup dup, balup dup. I know it's silly. I'm sorry about this, but trust me, you'll learn how to appreciate the onomatopoeia. Or it can be said like Toronto, 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 Toronto. It has the S4. It has much less diagnostic value because there are many causes of stiff ventricles, and you just can't tell the difference just by the S4. Quadruple rhythm, uncommon, also called trained wheel rhythm. It resembles the sound of a train wheels when crossing the coupling of railroad track. and it sounds like balub-de-boop, 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 balub-de-boop. Are you feeling it now? Yeah? Okay. So here we come, hard murmurs. Okay. This is quite a broad topic. Unfortunately, we will not be able to cover every aspect of auscultation of the hard murmurs. As with hard sounds, hard murmurs can be described based on their timing, location, intensity, and frequency. The timing of the murmur is probably the most important, along with the location. They can be classified as systolic, diastolic, or continuous murmurs. And back to onomatopoeia. That's the process of creating a word that phonetically resembles the sound. It is a really old school way how to learn hard murmurs or hard sounds. And I know that in 21st century, you would expect me to play you recordings of hard sounds, and you will get that in a second. And there are many great recordings, and you can do that on your own. I thought that this was a great opportunity to introduce you to this method. And I have to say, after years and years of practice, I've always said, oh, this is silly, I'm not going to do that. Somehow, this is the only way I still, after years of practice, I remember the sounds, and I remember how to distinguish the hard sound, systolic, diastolic, and all the murmurs. So bear with me, and maybe you'll find that useful as well. It will definitely help you with paces in cardio station. So systolic murmurs are caused by systolic murmurs caused by occur due to two reasons. Obviously they happen between first and second hard sound, and they are probably the most common hard murmurs that you will hear. And the first reason why they occur is when there is an abnormal flow over the outflow tract of the heart chamber or semilunar valve. Examples of these are aortic stenosis, pulmonic stenosis, and hypertrophic obstructive cardiomyopathy. The other reason is that when there is a backward flow from high pressure to low pressure chamber, as in mitral regurgitation, tricuspid regurgitation, or in left to right shunt, such as in ventricular septal defect. Now you could say that a left to right shunt as an atrial septal defect can cause a murmur, but that's the thing, that it doesn't. I don't know why. You don't hear a murmur from ASD, or you can do, but it's not that common. Diastolic murmurs are much less common, but they are very important to know, because if you have that, they tend to be much more problematic. They are audible during diastole, obviously, between the second hard sound and the first hard sound. And they happen due to one of the two reasons. First, when there is a backward flow across the semilunar valve, such as in aortic regurgitation or pulmonic regurgitation. And second, when there is abnormal flow through the atrioventricular valve, like in mitral stenosis or tricuspid stenosis. Continuous murmurs are a bit different. They do not respect systole or diastole, and they can occur anytime during the heart cycle. And the reason behind this is because they originate outside of the heart, and they don't respect systole, diastole. So this is the case in patent ductus arteriosus, or in venous murmurs or venous hum, or in arteriovenous fistula, coarctation of aorta, renal artery stenosis. That's not the heart. That's far from the heart, but that's the exact continuous murmur. Now the fun part. So after this, I'm gonna play you the video with the hard murmurs, but let's start with with the onomatopoeia of simple systolic hard sounds. And I practiced this, so please, I know I'm not the best, but bear with me. So normal hard sounds go like this. Loop doop, loop doop, loop doop, loop doop. When you have, that's a healthy person, obviously. When you have early systolic murmur, you hear shdoop, 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 shdoop. and that can occur in early mitral regurgitation. The most common probably murmur that you will hear is the mid-systolic, or sometimes called ejection systolic murmur, or the crescendo murmur of aortic stenosis. Loop, shtoop, loop, shtoop, loop, shtoop, loop, shtoop, loop, shtoop, loop, shtoop. Then there is late systolic murmur that I honestly don't know when you can hear a late systolic murmur, in what circumstances. Loop, 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 loop. Late systolic murmur and click of mitral valve prolapse. Loop, 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 loop. Now this is a bit tricky, because when you hear that on the video, there are lots of sounds coming in, and it's not that easy to differentiate. So practice this with when you have a patient with mitral valve prolapse. And whole systolic murmur, as in mitral regurgitation. Now coming to the much more tricky ones are diastolic murmurs. And I'm not able to practice all or to play you all of them, but the aortic regurgitation sounds something like this. Loop, 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 loop. So it's an early diastolic murmur just after S2. When combined with the aortic flow murmur, loop, 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 loop. Now this one I practiced, I think I got it, but it's just embarrassing. So the opening snap and mitral stenosis is a bit difficult, and I'll leave that to you. Try to practice on your own. This is even much more difficult. The classic continuous murmur of aortic of AV fistula, you heard, or everyone heard it. On the other hand, the venous has got inverse. Is louder in the diastole. And that's it. Thank you for playing with me. Just before I play the videos, the maneuvers that you should know about. So in inspiration, the reason behind it, what happens in inspiration, there is an increased venous return. So you suck basically the blood inside the right heart from the periphery, from the venous system, and you also decrease venous return to the left heart. You sort of keep that blood in your chest, and there is more blood across the right heart, and that accentuates the right-sided murmurs. On the other hand, with expiration, it's the opposite. So you increase venous return to the left heart, you squeeze that blood out of your chest into the left heart, you increase the flow across the left-sided heart, and you accentuate the left-sided murmurs. There are two exceptions to this. Bear with me. The exceptions are hypertrophic obstructive cardiomyopathy and mitral valve prolapse. They tend to, because of hypertrophic obstructive cardiomyopathy, when you increase, it's left-sided murmur, but when you breathe out and you increase the preload of the left heart, there is more flow, and the obstruction actually disappears. So and the murmur disappears, so it gets softer. But when this left heart struggles for the blood, when it's underfilled, that's when you hear the murmur. And this is the same with the mitral valve prolapse. So the Valsalva or squat to stand decreases the venous return. Passive leg raise increases venous return, and hand grip increases afterload. And hand grip is important again in left-sided murmurs, aortic regurgitation, for example, and ventricular septal defect. Now to the recordings, and enjoy a few minutes of heart sounds. So I hear that you can't hear it very well. Anyway, we're near the end. There is just only a split S2. Sorry about that. I thought it's going to be much more, the sound's going to be much better, but, you know, feel free to go. I find it's, you know, it's 4 minutes. It's got most of the hard sounds or hard murmurs in it. So if you just find it on YouTube, hard sounds collection by EMT Prep, I just randomly found it. It's quite nice and short. Feel free to play it. Sorry about the sound. Now, in terms of how I auscultate the heart, I think with time we're actually not so bad. I thought it's going to be much longer. There is going to be a demonstration in the end. There are many ways to approach this. There are many ways to skin a cat, and you should find your own one. Just please try to be, whatever you do and however you want to approach it, just try to be systematic and stick to what the system you have. And the way PACES taught me, or the way PACES required me to do it, is just simply to start by auscultation of the apex, in general, just supine position. Then what I tend to do is just to ask patient to, I'm focusing on the mitral valve, ask the patient to breathe out and hold it in there and listen if there's any accentuation of any heart murmur. And I try to roll him on the left side and listen there again with expiration and listen in the axilla. Then I roll him back. Then I'll go to the left lower sternal border without any maneuvers. Then I go to the, usually what I go to is the aorta or aortic area without any maneuvers. Then I go to the right upper sternal border. Then what I tend to do is just to ask them to breathe in and hold it in. And I'm trying to look, I'm listening to the split second heart sound. Then what I do is just ask them to sit forward, and then I listen at the lower sternal border again for aortic regurgitation. Just breathe out, as we know that the breathing out accentuates the left side of the murmurs. But as I said, there are many ways that you can do this. Find your own. Before we move on, any questions about this? There's not much to cover from here. If not, then I'll just move on to the peripheral signs. So the peripheral signs of heart disease, I don't find particularly helpful, except maybe for pulse, edema, and in ICU setting, or if someone's critically unwell, acral temperature on the peripheries, and color, skin mottling, and stigmata of infectious endocarditis are peripheral signs of heart disease, but I tend to. And then there is this famous clubbing that can be present in some cyanotic congenital heart disease. But there are many, many others, especially all the signs with aortic regurgitation. They're famous. So I'm going to talk only about pulse and edema because they're important. So the pulse, you can feel the peripheral pulse and in radiobrachial, axillar, popliteal, tibialis posterior, and the dorsalis pedis artery, and central pulse in carotid and femoral arteries. Now, what you should assess in when you're feeling for the pulse, you should assess the rate and contour, or the waveform of the pulse characteristic, and the rhythm of the pulse. But with ECG, rhythm is not that important anymore, unless it's a kind of a screening test if you want to know if someone can be in AF. So when it comes to rate and contour, the normal rate obviously is 50 to 100 beats per minute. Varies literature to literature. Some people say 60 to 100, doesn't matter. The normal pulse waveform looks like that. In pulsus alternans is when there is a beat-to-beat variation of the amplitude of the pulse, and it can be seen, for example, in cardiac tamponade, classically. In tamponade. It can be seen in severe cardiomyopathy, like severe ventricular dysfunction. Pulsus bisferiens is when there is a aortic regurgitation, but these waveforms are important, not as a bedside examination, but when you have a patient in ICU who's got an arterial lining, and you can see that on the monitor. That's that's perfect. Oh, that reminds me, when you're on the monitor and the patient has pulsus alternans, it also can tell you, and that's very important sign in the ICU, is that the patient is hypovolemic. I don't know exactly the evidence behind it. I do apologize, but it was quite known, and I think it quite worked to when we're assessing patient, that if they have bit-to-bit variation, like significant variation, that the patient is hypovolemic and needs volume rather than pressors, for example. Necrotic pulse is sign, again, very poor sign in poor LV. Don't know much about that. Pulsus paradoxus is not much about the pulse as it is about the blood pressure. So even though, and it's that on inspiration, there is a drop in blood pressure of more than 10 millimeters of mercury. And it's not that the drop of blood pressure, that's the paradox. That's a normal response when you breathe in. But it's the fact that it's more exaggerated and that's more than 10 millimeters of mercury. And it's seen in cardiac tamponade. Not that you have time to do this maneuver in cardiac tamponade anyway. In severe asthma, and something else I forgot. Pulsus parvus et tardus, slow rising, low volume pulse, classically seen in aortic stenosis. This is the most common pulse that you will be able to see. And then you have the hyperkinetic pulse. When you feel in the pulse, I think the most important bit, if you have to forget all of this, what you have to remember, and I'm sure you know this, is beware of the pulse deficit in EAF. Classically, you have a patient who, when they do clinical observations, when they do vital signs, the nurse comes and checks the pulse, and the pulse says, oh, I counted as a 60. And then you go on and you assess the patient and you auscultate the heart, and the patient goes, and it's because the patient is in AF, and in patients with AF, not every beat transmits as a pulse, and they have pulse deficit. So you can this can be quite significant issue. And I had a patient, fortunately, who's been in AF for 2 days. I kid you not, 2 days with the heart monitor. That every fast AF of 150 every day, observations 3 times a day, even more, were recorded as pulse like 60, 70, and the patient was running 150. It was only the technician who called us like, oh, do you know this patient has got fast AF? So always auscultate in AF. Edema is causes when there is an imbalance of Starling forces, and this is where you need to remember now your pathophysiology and your biophysics. So you've got 2 main forces, that is your hydrostatic pressure and the oncotic pressure, and then there is the permeability of the capillaries. So when there is an increased hydrostatic pressure, such as in congestive heart failure or Crohn's venous insufficiency, you can have edema. When there is a low oncotic pressure, such as in hypoproteinemia, in nephrotic syndrome, in liver disease, you can have edema. When you have impaired permeability, such as in sepsis and leaky capillaries, you can have edema. There are 3 main types of edema, but 2. One is pitting edema, or called venous or like low protein edema. It's when you touch the patients and you can see the pitting. There is a non-pitting, such as in lymphedema, or called high protein edema, and there is also a third one, which is also a non-pitting, and it's called lipedema, and it's when there is just deposits of fat. Now, the thing about the pitting edema is that there are many causes of pitting edema. So the pitting edema itself does not tell you much. It can be caused by the heart disease. It can be caused by the liver disease. It can be caused by the kidney disease. It can be caused by the chronic venous insufficiency. It can be caused by the sepsis. It can be caused by medications. Classically, is amlodipine, which causes lower limb edema. And so it doesn't tell you that if the patient's edema doesn't tell you anything. It can be even physiological, some in pregnancy, or in obstruction of the, no, it's not physiological, you know, when you have mass in the abdomen and obstructing the veins, or at the end of the day. Then when it is helpful is when you have a raised JVP and an edema. Then you can tell this is a heart-related problem, or at least part of it is heart-related problem. When you have just isolated peripheral edema, you don't know. And where should you check? So you should check with independent places or gravity-dependent places. That means if the patient is sitting, you check for the legs, obviously. If the patient is standing, you check for the legs. The trick is when you have old, frail patients who lie in the bed all day, or ICU patients, and you can check their legs and they're fine, and they're not that swollen. What you have to check is the sacrum. You have to check the back, the shoulder blades. In ICU patients, typically these are the places that you have to check. So you have to go and dig under the blanket and check. Any questions about this before we move on to the great topic, and that's one of the most important things that for clinical practice, volume status. Much more important than heart murmurs and anything else. And I promise that's nearly the end. All right, so volume status. Essentially, it means that there is a problem with the balance, but what it means is it represents the balance of sodium and water in a patient's body. And if there is a depletion or excess of one another, there can be an abnormality of the volume status. It is probably the most essential, no, it is absolutely essential skills of every doctor, and you will deal with that daily. You will make much more decisions based on patient's volume status than any other previous examination findings that we discussed today. It is not a singular thing, volume status. It cannot be quantified with simple number yet. It is a spectrum of one side there is a hypovolemia, and on another there is hypervolemia. And somewhere in the middle is this mythical euvolemia that no one can tell what it truly is. You can describe hypovolemia. If I'm going to ask you now what it means, you can tell me the signs of hypovolemia. You can tell me the signs of hypervolemia, but tell me, how do you define euvolemia or normal volemia? It is much more difficult. And here comes one of my all-time favorite studies. So this was a study published in 1987. 1987. It is the time of the old school experienced clinicians who were trained on all these venous pressure thingies, and they were masters of this. These are all your professors at med school. They took 58 non-edematous patients who had hyponatremia, a nemesis of yours in hospital. So basically, they were non-edematous, and they asked the clinicians, is this patient euvolemic or normal volemic, or is this patient hypovolemic? And now I need your cooperation a little bit. So tell me, how many, what's the percentage of the physician or the doctors that got it right? Guess. How many of them got it right?
5%?
5%. 10%. Oh, you're very skeptical. I painted this very skeptical picture, but 25. It's higher than a 20. It's 50. So Andrew Jackson is the closest. So it is 48% in euvolemic and 47% in hypovolemic patients. And when you think about it, this is worse than flipping a coin. So how good are we at assessing if this patient is hypovolemic or not? Sorry, the objective methods were to assess, to check the renin and norepinephrine in the blood, and then they checked it. So how good are we with the assessment of this? We are, we pretend that we know stuff. We pretend that we know whether this patient is this or that, and we make decisions, huge decisions, like whether to give more fluids or not, or whether to give diuretics, and it just has a significant impact of the hemodynamics of the patient. So the point of mine, it's much more difficult than that, and the more I know in the last years or two, with and now with interest in the echo and the bedside ultrasound, I find it much more difficult to tell whether this patient is the fluid status just by looking. Hypervolemia is a bit different. If they're overtly hypervolemic and if they're congested, then you can tell that. But the euvolemic or hypervolemic is difficult. So okay, so this is an excellent infographic that I found on Twitter by a very enthusiastic another doctor. I forgot, I didn't save his name. I'm sorry about this. And it shows you the signs of hypervolemia and hypovolemia. So in hypervolemia, you can see that just by the vital signs that the patient can be hypertensive, they can be hypoxic if they have pulmonary edema, and they obviously their weight has gone up. From the cardiovascular exam, you know that the neck veins would be distended. There will be positive abdominal jugular reflex. There may be S3 present, and if there is, then with this likelihood ratio, then you're happy because now you know that the patient has got LV systolic dysfunction. There is edema, but it's not always present. But you look for dependent areas. Sacrum, genitals is are often missed, and patients have a huge scrotum, and you just don't know about it. In ICU patients, check for the thorax and abdomen. In respiratory, so look at this, crackles. How many of you have been told to listen to the lungs for any signs of fluid overload? Look at this likelihood ratio, just for you to understand. If the likelihood ratio is 1, it doesn't change your previous probability. Basically, so you're asking yourself, is this patient overloaded or not? And you have this suspicion, or you've got this probability in mind, and you do this test, and this test will not shift your probability either way, almost not at all, very minimally. So how useful is that to listen to the lungs? Probably not much. The same goes for, actually this is a bit more useful, but the difficulty with this is decreased breath sounds and asymmetrical chest expansion, donors to percussion is more indicative of pleural effusion, and if that's present, then yeah, you're happy, but it's not always that. So again, subtle fluid overload is maybe difficult to interpret by the clinical means of clinical examination. On the other spectrum is hypovolemia. Again, patient is tachycardic, can be hypotensive, and can be, but if neither of these are present, check for orthostatics. That means stand the patient up from lying or sitting position and check whether their heart rate has gone up and whether their blood pressure has gone down. And if yes, then you can tell that they're probably fluid volume depleted. Cardiovascular, if the CVP is less than 5, therefore if you can't see anything, that you can tell that with the you can tell for sure that the CVP is low. But the CVP and volume status is a topic for another day, for another hour-long lecture. Long story short, it doesn't correlate very well. Capillary refill, sure, if you find that useful. Skin turgor, don't know. Dry axilla is one of these things that people say is very reliable. I'm not usually testing that myself. And then dried mucous membranes, sunken eyes, and tongue furrows. But again, you know, if you don't have tongue furrows, you can't say that the patient is not hypovolemic. So it doesn't really. It's not very reliable. So don't just check for the tongue. Now here comes the fun part. The ultrasound is much better at this, and if the sign of hypovolemia, or like at least not hypervolemia, is when the IVC size is normal size and is collapsible. And then you can also check for neck veins if they're distended or not. But you should see that by that side. You should also differentiate between volume depletion, which is loss of, or hypovolemia, which is loss of sodium and water, and dehydration, which is loss of water only. Now, I think we're nearly the end. I think there's only one more slide, but I just want to summarize things myself. And so here's the question: any questions about this? Volume status is going to be, trust me, it's not that simple, and probably maybe even not that difficult. But you know, the more you know, the less you know, kind of. So how to approach let's put it all together. So we've talked about individual parts, and there are many ways to skin a cat. You can approach the sequence anatomically. You can do it head to toe, and you can do it in a system-based approach, like ABCD or assessment of ICU patients, where you start with like sedation, then you move on to respiratory, I don't know, renal system and stuff like that. It doesn't matter which one you want, which one you use. Just find one and stick to it. Plus, minus, make some modifications for individual patients, and practice it. Because, as they say, practice makes perfect, but that's not true. It's only perfect practice makes perfect. So make sure that you perfectly practice it. Now I'm going to show you a 6-minute cardiovascular examination that they want you to do in PACES. So if you're going to end up in the UK, this is what you'll have to master as a physician.
Yourself to the patient, state in your full name and role, ask permission, and check if the patient is in any pain. Expose your patient appropriately. Reposition the patient lying down at a 45-degree angle. You may now begin the examination with inspection from the end of the bed. Look at the patient for any signs of breathlessness, distress, or any obvious scars. Look at the surrounding environment for oxygen, fluid restriction signs, GTN sprays, or any other clues. Start your peripheral inspection with the hands. Look for peripheral cyanosis, examine the nails for clubbing, splinter hemorrhages, Osler's nodes, and Janeway lesions. Feel for warmth, sweating, or clamminess. Test capillary refill time by pressing the nail bed for 5 seconds. Release and count how many seconds it takes for the colour to return. It should be less than 2 seconds. Palpate the radial pulse, assessing rate and rhythm. Then move to the brachial pulse and assess its volume and character. Now assess the collapsing radial pulse. Whilst feeling the pulse, raise the arm above the height of the heart and note any change in volume and character. At this point, you should measure the blood pressure. Check the eyes for corneal arcus and periorbital region for xanthelasma. Inspect the conjunctiva for pallor. Look at the lips and tongue for central cyanosis. Assess the jugular venous pressure height. Measure the level of the jugular venous pressure with reference to its height above the sternal angle. Palpate the carotid pulse and assess its volume and character on both sides. Inspect the chest wall for previous scars, pacemakers, abnormal pulsations, and a visible apex beat. Palpate for apex beat, heaves, and thrills. Now auscultate the heart. Listen with both the bell and the diaphragm of your stethoscope at the apex, base, aortic, and pulmonary regions. Start with the bell at the apex, then switch to the diaphragm for the other cardiac areas. Start by listening to the heart sounds. To help you differentiate between the heart sounds, they should be timed against the carotid pulse. Listen to the first heart sound. Now listen to the second heart sound. Listen for murmurs. These should also be timed with the carotid pulse. Now roll the patient onto their left side and listen for murmurs. These should also be timed with the carotid pulse. To listen for an early diastolic murmur signifying aortic incompetence, you should ask the patient to sit forward, take a deep breath, breathe out, and hold their breath. Auscultate over the carotid arteries for bruits. Now ask the patient to sit forward and listen over the lung bases for crepitations, which may result from pulmonary edema. Check for sacral edema. Now move on to the lower limbs. Check for ankle edema. Ensure you check both legs. Check the peripheral pulses on both legs. The femoral pulse. Auscultate for bruits. The popliteal pulse. The posterior tibial pulse. Here you can see the doctor confirming the patient's pulse and not her own. Now feel for the dorsalis pedis. Finally, explain to the patient that your examination has been completed.
So Yeah. So finally, I just want to say two things, and that's things that matter, and I think, or at least what I think that matter in cardiovascular examination. And always try to assess for perfusion, and that's your forward flow, whether the patient is warm or cold, and whether it's good color or pale. And assess for any congestion, whether it's dry or wet, by peripheral edema or crackles on the chest. This is your 2-minute cardiovascular examination, and is one of the most important hemodynamical assessment that you can do at bedside. Then it says the rhythm, whether it's regular or irregular, any valve defects by the auscultation of the heart. It says the volume status, but now you know it's not that simple. And these are the matters. These are the things that you should do, whatever way you want to do. Things that are probably useless, or at least I don't like to do, and they don't have very much evidence or more place in modern practice, is I don't look for stigmata of infections of the carditis. It's no longer diagnosed with that. They don't tend not to present that late. They don't have developed any of these. When it's present, fine, but you need blood cultures and need echo. Clubbing doesn't have any much more information. Collapsing pulse, never seen one in my life. Eye exam, yeah, they have corneal arcus. Palpation of precordium. Now I'm a bit contradicting myself because I told you earlier that it is a great sign if it's present. The lateral displacement, you can tell the heart. There's a systolic dysfunction. I tend not to do it. And venous waveform, it's super complicated, and it just doesn't add much information at this point. There are other methods of investigation. And 3 things that I wish I have learned sooner, and this is what I encourage you to do. First thing, point of care ultrasound, point of care ultrasound, and point of care ultrasound. You can't. We tend to the X-ray and the X-ray and the stethoscope have combined age of over 300 years, and it's just they're so old, and it doesn't have much value. It's very traditional kind of thing, and it's very cheap. But now things are getting cheaper. You can get a handheld ultrasound for like £2,000 now, which is super cheap. You can just plug it in your phone, and you can easily echo someone. You can easily visualize the pleural effusion, or whatever. This is the way forward. This is the new stethoscope. This is going to be mandatory, and even now it's mandatory of many curriculums of postgraduate education. In acute medicine in the UK, it's mandatory. Respiratory lung ultrasound is mandatory. In the US, first year medical students, the med school gives them this ultrasound probe, so they can practice. This is the future. So Google it now and start now, because even today is late. And with that note, I'm gonna leave you. And if there are any final questions, by all means, fire away. The references. The main one I want to show you is this great book, Evidence-Based Physical Diagnosis. There is a new version coming in September. It will change your perception of the physical examination, and it is super useful. It's very cheap, and it's just a great book, but you will spend long days and hours just going through that, because there's a lot of information. So with that, thank you. If you feel free to contact me by any means, or just get in touch. Thank you for listening. Thank you for having me.
Thank you, Dr. Vataha, for that very informative lecture. I really enjoyed it. I think everyone who's been tuned in so far would say it was incredible.
Don't forget to practice Onomatopoeia.
Yeah. But if you wouldn't mind, could you possibly move on to the next slide?
Yeah, I'm sorry. Yeah.
No worries. So just a quick notice before I kind of release the feedback form. Next Wednesday, we will be having another doctor from the UK, Dr. Rabindran, who will be talking about the ENT exam. So for anyone interested in ENT, for exams and just for clinical purposes, please do come along. And hopefully you'll be learning more and more week by week. So next week we'll be talking through the ENT exam, and the dates for your calendars are the 23rd of June at 5 p.m. Czech time. And Dr. Fataha, if you wouldn't mind moving on to the next slide.
Yeah.
And here's the feedback link for everyone. Please fill this feedback form out. It's a great opportunity for you to be added to our draw. It's great for Dr. Fataha, for example, for us to kind of receive all of the feedback from you to see how we can improve or what we did well. And yeah, after you've completed the feedback form, you will also receive a certificate of attendance, which you can use for all of your CV folders, etc., etc. So that's the link. I've just posted it here. I'll also post it on our YouTube. And with that, I would just like to say another final thanks to Dr. Fataha for giving up his time. He's a very busy internal medicine trainee in the UK, and it's been a privilege to have him here and tell us about his own personal experiences and to try and teach us the new modern way. And for sure, I will definitely be investing in a point of care ultrasound probe if I can.
It will pay off. It will pay off.
Did the hospital give it to you, or did you have to buy it yourself?
I got it for my 30th birthday.
Boys and their toys, I guess.
Yeah.
But thank you very, very much from myself and from everyone from UIMS and also all of the students present today. It was a pleasure to have you, and I think everyone learned a great lot from you. So thank you very much, and hopefully we have you back in the future as well for other cardiovascular and respiratory talks. But for this evening and tonight, thank you to everyone for turning up, for giving up their free time. Hopefully you found it useful. I'd just like to give a big thanks to all of our partners and sponsors as well. So that is OS Implants, Scrubbed In, MySuture, and QuesMed and Anastomos, and Medal as well. So thank you everyone for joining, and hope you have a nice evening. Thank you, Dr. Fataha, once again.
Thank you for having me.
And yeah, see you guys next time. Thank you.